All right. Hello. I believe my camera is still working up. But hello, I'm Andrea Fourquet, and as stated, I'm the technical co-chair of patient care coordination. Next slide, please. Just some background. The patient care coordination domain was established in 2005. Its goals are to solve integration issues that between providers and patients. And supports the clinical care aspects of document exchange. And we also have some workflow profile documentation to help work through the standards development in those areas. The main mission is to maintain interoperability profiles and support coordination of patients and care providers in the healthcare settings. Next slide, please. First piece that we wanted to mention for our profiles and our testing are that we have occupation options. So this is referring to our occupational data for health testing options. We've added this as a testing option within our within all of our summary document profiles. And it essentially is the structured data for occupation and industry that can be sent in those summary document profiles, primarily in the social history section. While it's not its own specification on its own, as much as it's an option, it is supported in both the FHIR and CDA document types as well. And it is with the goal of slowly standardizing the collection of the work industry information that will help manage work-related health risks and health conditions related to workplace injury or exposure within healthcare document summaries. And just as a side note, is also one of those options that can be tested within the International Patient Summary Profile for testing as a testing option for an example. Next slide, please. We also have our 360X profiles. These are profiles that are working to close the loop for referrals from primary specialists to the provider that had referred the patient in the first place. So again, this is working with exchange between providers and then referrals to a specialist of some sort, and then informing the provider that the patient had arrived at the specialist and been treated, and information kind of goes back to that provider on items such as, you know, they attended their appointment, this is what maybe had been done in that appointment. The 360X profiles also have sister profiles for this. This is 360XL. So again, this is an extension of the 360X to include acute care for long-term care facilities. And in addition to that, they have sub options for home health and SDOH elements as well. So this profile and its related profiles are working within this type of coordination of patient care between specialists and primary providers. Also with transactions that are considered FHIR transactions as well. Next slide, please. Querying for existing data. This was a item that was created jointly between the ITI domain and PCC. This is primarily to support querying for relevant clinical data elements, so allergies, conditions, etc. And this is going into the details and semantics of the message transport between the clinical data consumer and clinical data source, variations over content creator, content consumer related to our list of resources within that profile that you can review. Again, this is for FHIR. We have a query for existing data for that was initially created for non-fire transactions as well, but the QEDM is specifically for fire resources. Next slide, please. We also have a maternal health profile suite. We in PCC have seen interest in maternal health and maternal health interoperability increase in over the years, and we wanted to bring the attention that IHE has many established pregnancy-related profiles. So here in this list, the antepartum summary, the antepartum profiles, labor and delivery profiles, discharge summary profiles, and postpartum profiles. The diagram on the right can show you the flow of information from the antepartum period into this postpartum and pediatric care piece. So all these documents connect in that information flow. We also have an emerging profile that we expect to be published any day now. Officially for trial is the mobile antepartum summary profile. This is a fire profile that utilizes the antepartum summary, antepartum education, antepartum labs, and antepartum history and physical profiles and combines them into a proper fire summary. It takes the structure of the IPS profile and utilizes it for maternal health care. The main difference being that it can reference encounters and therefore it is not a true IPS, but it uses a lot of the same sections and elements and data elements that are expanded upon for maternal health care and tracking. And again, for the CDA profiles here, many of these IHE sections are aligning with the IPS section requirements. So IHE medical summary sections have a strong correlation with not correlation, are easily supported by IPS sections. So if that is of any interest to review or consider for testing, these are available. Next slide, please. So going into the international patient summary, we do provide testing for the international patient summary based on HL7's implementation guide and the ISO requirements. There are 3 testing options available for IPS. There's the base, which is the minimum requirements defined by HL7, defined by the HL7 fire and CDA implementation guides. ODH, as mentioned previously, this is the testing option that will require the support of the social history section, and we'll be testing how work-related data elements will be supported within the IPS and its structure, and then the complete option. And this requires that all of the sections that are in the international patient summary IG are supported for the testing event. So the patient that will be required here to test in this one will have all of those sections, will have data in all of the sections, and you'll be required to support or display support for those. That complete option is essential for utilizing IPS as a data model for secondary use. So there are some core profiles Lori will go into that may utilize IPS as a data model as an option for implementation. And this complete option would help support that as a base. While the fire IPS profile has recently published an update, and we expect the CDA to follow as well prior to this testing event. We will be testing against those updated versions, not necessarily the most updated version that IHE has published at this time. So that is an expectation to be aware of. We encourage everyone to utilize a transport option for the testing event as well. So we'll be testing, PCC tests the content of the profile, but we also encourage choosing any one of our standard transactions to test with the IPS. So That can be PCC1, that can be MHD, that could be a number of, it could be XDS, like it could be a number of any of the transactions that are defined by ITI. And speaking of ITI pieces, there is a profile in ITI that supports the sending of IPS, and it defines the different transactions that can be used. And when you register for that, you can also register for SIPS, and there will be a testing plan that kind of combines those two elements into the testing program. Next slide, please. We also have emerging from PCC some paramedicine profiles. That would be the paramedicine care summary. This is a document that takes information that is documented in paramedicine event and allows for that data to be shared to a receiving provider, system, or organization. And there are two document types: the clinical subset, which is utilized for patient history and interventions, relevant to providers' transfer of care, and a complete report, which provides a complete detailed report with information such as, height of the fall and things that are maybe less interested in a moment of transfer of care than it is for quality metrics and reporting to maybe registries. This profile utilizes, again, the IPS defined sections to support an encounter, but it is, again, not a properly defined IPS document. And again, both CDA and FHIR supports for this document type. There's the routine interfacility patient transport profile. It is a transfer of care summary document that goes from a provider system to a paramedicine system. So again, it's similar, but not as robust as the complete report for the paramedicine summary, and is mostly patient summary data plus referral information. And then we have, this is actually a QRF profile. This is the quality outcomes reporting for EMS. This kind of brings it all together, where completion of care for the patient in a receiving facility, then the EMS provider is able to get an outcome of the patient, such as survival or death, information on their care so that they can do their own quality metrics, calculations and reporting. And the diagram on the bottom right kind of shows this flow of information. So we have these paramedicine profiles if anyone is interested in registering for those and testing as well. And with that, I believe that is what we have for PCC at this time. We have a number of established profiles already in place, but these are kind of the new up and coming and pieces that we have information on. And with that, I can transfer it back to Nicole.
Yes, thank you, Andrea. And thank you for this interesting presentation. And now it's time for Lori. So please, Lori, the floor is yours.
Yes. So if you could put on the next slide, please. And thing here. Sorry. There we go. All right, so just a little bit of background. The Quality Research and Public Health domain was established in 2006. It addresses the infrastructure and content that's necessary for sharing information that's related to quality improvement, for improving the primary care systems and clinical research systems, and providing population-based health surveillance. We originated in the patient care coordination domain, and the types of profiles that we ended up with are all about secondary use of data, which is part of how we spun off into QRPH. Next slide, please. One of the fundamental challenges that we have in all of the quality public health and research activities is it's not part of the primary care's normal clinical routine. So it's very inconvenient to get that reporting out, whether it's required reporting or voluntary reporting, clinical trials reporting, it's burdensome. And so these profiles that we work through in QRF are intended to improve that interoperability and efficiency, remove some of that nuisance factor, remove duplicate data entry issues that come along with the secondary use domain. Next slide, please. Okay, I'm going to cover a couple of different profiles that are recently out. The first one is actually MADX. This is Aggregate Data Exchange. We previously had just the Aggregate Data Exchange and some content exchange profile on top of that for HIV. This is intended to define structure for measurement and aggregate reporting to organizations, for instance, WHO. The WHO has been working, this is a broader picture. The profile itself actually fits in one of the other layers, but they have a 5-layer framework representing the WHO content for digital health components. In the first one, they are those are the actual measures, et cetera, that they use. It has a lot of narrative content. And then to turn that into more of an operational measure, they get into the second layer. They have some toolkits. They're not profile-based toolkits, but they feed into it. So once you get to the third one, that's really where our profiling comes in, which is a machine-readable layer, which provides the interoperability standards needed for the FHIR, formatted in this case with the MADX is the FHIR ID. The part of their kit, again, they've provided some background here in all of the components that lead into defining what those metrics are that they're looking for and turning that into machine processable. If you could go to the next slide, please. And that's actually the diagram of their toolkit. Next slide, please. Oops. Okay, so within that whole framework, they've diagrammed inside the including the structured FHIR content. They can then start adding dependencies on MADX, IG, be able to test compliance with it to fit in that entire framework of aggregate data reporting. Next slide, please. Okay. The second newly released profile from QRP is the Clinical Care Guidelines, the CCG. This is an update to some prior work where we had done some pause waiting for HL7 standards, underlying standards to be finalized. This is actually part of a Gemini project. It's a rather complex full system. We have multiple use cases within the whole framework of clinical care guidelines, and I'll break that down in just a minute. Next slide, please. Some of the fundamental concept here, why we need the automation of clinical care guidelines. We need to try to improve care, overlapping this green zone. This green zone is really what was done, what should have been done, so you were in compliance with the clinical care guidelines. And there are things that were done that perhaps weren't part of the guideline. That would be errors of commission. Those things that should have been done that weren't are errors of omission. And so this profile is intended to address those aspects. Next slide, please. The first part is the publication of a guideline. We have a number of transactions to be able to publish and retrieve guideline information. This current profile is written with a dependency on IPS as a data model, but there's an expectation that if it is not an IPS as your data model, you're free to use whatever national model or regional model that you need for your to define your guidelines. But the IPS does provide common concepts, things like laboratory results and allergies and meds and problems, et cetera, that are all key to establishing a clinical guideline. So you do have the option to define your own data model within volume 4. Next slide, please. Okay. Those data would be published to a guideline repository, and a local guideline engine that might be operating, say, within an EMR would have access to that guideline repository and be able to query for the latest and greatest clinical guidelines. Next slide, please. Okay. The next part is a care plan contributor. Now, we have a dynamic care plan. So these are actually PCC profiles for dynamic care plan, where you see the transactions listed there. So as the system would identify an action that should be taken on a care plan, given the patient's conditions and the guideline, there may be contributions to the care plan. You may retrieve that care plan, identify it, and perhaps provide updates to it. Next slide, please. Okay. And then there's a looping. So many patients have more than one condition. They may be subject to multiple clinical care guidelines, and that requires that the system loop through and make sure that they've exhausted all of the guidelines that pertain to that patient before completing its recommendation. Next slide, please. This is a diagram of a conceptual community. You can see there are multiple players. This is primarily informative, but you can see where we've got testing and compliance with Catalyst in the red, and the Digital Health Agency publishing. It's directed through this conceptual Ministry of Health. So you can see the whole ecosystem here. And we may or may not have some level of plugathon interest for Brussels. So we will keep abreast anybody who expresses interest. Next slide, please. Oh, and there is a more detailed video if anyone is interested in diving in a little deeper into clinical care guidelines. There's a reference here. Derek Ritz has published a very nice comprehensive short video. Okay, next slide, please. The third topic that I want to talk about isn't a profile per se. It is a white paper. QRPH has published and is in the process of updating a white paper for using IHE profiles for healthcare secondary data access. And there's a couple of use cases defined already, which mostly reflect currently as well. And just a little additional background, in our last Connectathon and workshop, we identified this as one of the considerations for the European Health Data Space 2 for secondary use. So we're working through this document to refresh it with more FHIR components, et cetera. But you can see the use case from this diagram is you have a research community that would like to access, perhaps it's in an HIE, perhaps it's a national body, data that is stored in that in a clinical community, and they may or may not share this same patients. This particular diagram was based on clinical research for, say, medications, clinical trials, where they actually do have patients in their database that they would be interested in supplementing their data with the clinical community content. Next slide, please. The other use case is actually in the clinical space that they might want to access data from clinical trial space. So this is what it speaks to now. Next slide, please. Okay, the secondary data access, it actually models all of the underlying data access mechanisms, the XCA, XDS type access via initiating gateway. There's something that they have in common, this box in the middle with a trusted third party, is a de-identification activity. And that at this stage is guided by the de-identification handbook, which is an ITI work item, and that work is actively being updated. And so we are also contributing a secondary use case here for clinical access with respect to EHDS2 that could be used to conduct that or as a guide for conducting the de-identification there. Also, the other update, I think I mentioned in part, but right now it speaks to XCA, but ITI has published numerous FHIR-based infrastructure profiles that we will also want to call out, but conceptually, the process will be the same. We're going to be looking for requesting data, de-identifying it after doing the cross-community patient matching, and then releasing that to the requesting community. Next slide, please. And as I mentioned, they identify multiple approaches to going after the clinical data. In this case, it's using query for existing data. Will be updated to include also QEDM, which is the FHIR-based equivalent to that. And again, you can see it's really the same structure for secondary access. It's just a different mechanism that's being defined here. And notice that these are not new profiles. These are pointing to existing IHE profiles that can be leveraged for secondary use. Next slide, please. The de-identification handbook, just a slide on that because we've been participating and contributing to the secondary use case as an example of FHIR-based de-identification. And family planning also came out of QRPH. They support DICOM example. We'll be updating a V2 example. And it's actually the FHIR and CDA process is really the same. It's just the mapping that's different. The example that we provided is using the International Patient Summary, the IPS, kind of like what the Clinical Care Guidelines is doing, but in this case, it's using that as a source of data, and there are many systems that can do a $ summary or otherwise exchange structured format in IPS for an IPS structured format. Also, we have a vital records death reporting that can provide exchanges for mortality data, and mortality being one of those key outcome analytics that we use for quality measures and in public health. So this example includes both of those and some de-identification mechanisms. Next slide, please. Okay, there are, only to call out some of the other submission options, you're going to see all of these are ITI profiles. There's message-based, FHIR-based, CDA-based, and of course, retrieve form for data capture, which is where you're filling in a form and pre-populating that form from, say, your accessible clinical data. It has a sister profile that's FHIR-based, and then the IT infrastructures, the MHD, the XDR, and you can see it below that, basically XDS, submissions to a health information exchange where the requester could potentially be requesting that data through the HIE. Next slide, please. We would invite participation. We meet jointly with Patient Care Coordination. Weekly telecons are Thursdays, 12 to 1 Eastern, 6 to 7 p.m. Central European Time, and we can alternatively schedule various topics. And also, if you're interested in participating in the ITI de-identification discussions, they are bi-weekly Thursdays, 9 to 10 Eastern, 3 to 4 Central European Time, and active discussions going on in those updates.